us. My name is Sarah Curley. My pronouns are she, her, hers, and I am a prevention coordinator with the Wisconsin Coalition Against Sexual Assault.
Good afternoon, everyone. My name is Angie Railing. My pronouns are they, them, theirs, and I'm also a prevention coordinator at WCASA.
I'm Peter Fiala, Events and Technology Coordinator at WCASA. Hello, everyone.
Thank you all for joining us this afternoon. Today, we're going to be going over part 2 of our webinar series on HIV and what we would like advocates or preventionists in the sexual violence field to know. And we are joined by Ruthie Burich-Weatherly, who's a public health consultant at Riverside Consulting, and Joanna Woodbury, who's the Director of Social Services at the Medical College of Wisconsin. If you haven't already, please make sure that you register for part 3 and the final part of this webinar series, which will be on Tuesday the 6th with Amanda Schumacher. We're so excited to have Ruthie and Joanna with us today and to learn about the resources for folks who might be seeking treatment for HIV and learning specifically about what that looks like here in Wisconsin. So without further ado, I'll hand it over to Ruthie and to Joanna.
Thank you so much, Sarah. Thanks for this invitation to speak today. We're very excited to share this information with you all. My name is Ruthie Burich-Weatherly, and I'm a public health educator. I've been working in the field of HIV prevention for about 15 years. I help folks access HIV and STI testing, care, and treatment at my day job, and advocate for PrEP use on social media through a page called Let's PrEP Wisconsin. I'd like to introduce you to my co-presenter, Joanna Woodbury. Joanna, if you could introduce yourself.
Hi, everybody. My name is Joanna Woodbury. I direct HIV care and prevention for the Medical College and Froedtert. I also oversee social services for our Inclusion Health Clinic. I have done work in HIV care and prevention for about 16, 17 years, and I've been with the Medical College for 11. I am a trained social worker, so there are functions of my work that you'll hear about today that are patient-facing and specifically supporting folks who come in through our ER to access PEP or PrEP and following sexual assault.
Thank you. We can move on to the next slide. So today we will cover information about HIV post-exposure prophylaxis and HIV pre-exposure prophylaxis. We will discuss the who, what, when, where, why, and how of accessing PEP and PrEP for HIV acquisition risk reduction. That is, how do you prevent an HIV infection before or after a high-risk encounter? Next slide. And one more. Thank you. So nPEP is non-occupational post-exposure prophylaxis. The N is only an important distinction because it assumes that this potential HIV risk exposure happens outside of work. The actual use of PEP is the same in that it's the same medication used, but the how is much different. If you are working in a setting where you might encounter someone else's blood through, let's say, a splash to your face during surgery, or an accidental needle stick injury, if you are perhaps giving an insulin injection to a patient, your place of work would have very specific set of protocols in place to help you with the next steps. They may require you to visit your occupational health center or talk to a doctor that would ask you questions and determine the next course of action. This is important because you must follow your workplace guidelines if this exposure happens at work. The discussion that we're having today is going to specifically reference non-occupational PEP, which would happen or could happen outside of the workplace setting. PEP is a regimen of 3 anti-HIV medications that work together to prevent HIV from replicating and establishing an HIV infection inside of your body if it's introduced through, let's say, another person's needle, sexual assault, or perhaps a condom breaks during sex. It can be used in any instance in which a person was introduced to another person's bodily fluid where HIV can be transmitted. These fluids are blood, semen, vaginal fluid, or breast milk. It can also be in other fluids where blood is present, perhaps saliva with lots and lots of blood present. That example is a very unlikely scenario that we refer to as a negligible risk, but something that we should mention for your awareness. The regimen of medications must be started within 72 hours in order for this medication to work. After 72 hours, PEP is not recommended, so time is of the essence. Next slide. Additionally, there is some baseline testing that must be completed in order to, one, establish the individual who was exposed is not already living with HIV. Two, the pregnancy status of the individual. Pregnancy does not disqualify the pregnant person from PEP, but it does influence the PEP regimen. This is the combination of the medication that would be used. Some anti-HIV medication is not safe for a fetus. And third, hepatitis B and C. It's important to know if someone has chronic hepatitis B or is living with hepatitis C in order to connect them to care and treatment for that, or potentially change the PEP regimen, as some nPEP regimens also are active against hepatitis B. Syphilis, gonorrhea, and chlamydia testing is recommended because if you find any of those infections, you would want to treat them immediately. And lastly, depending on the treatment regimen chosen, kidney and liver function testing is warranted due to the potential impacts these medications have on kidneys and livers. Typically, these kidney and liver function tests would be done universally. Next slide. So let's talk about when PEP is warranted and likely not warranted. We all know that there are some theoretical risks associated with HIV. There are some times where PEP is likely not warranted. There needs to be an exposure from a bodily fluid that carries HIV and an entry point for HIV. So for example, condomless rectal or vaginal sex from a person with an unknown or HIV positive status is a risk. Someone spitting on your leg is not. Someone biting you is likely not. Condomless oral sex is likely not. This graphic can help guide a practitioner and a patient through the risk versus non-risk scenario to help inform whether PEP is warranted. This is often a discussion between a patient and a provider to discuss the risk of exposure. It can also help the practitioner and the patient decide if there's a medical benefit to taking PEP. There are perhaps, and we shouldn't overlook the psychological benefits to taking PEP in addition to the medical need. This can also be a discussion between the provider and the patient. If the risk was negligible, but the anxiety caused by not taking PEP, and that would be so detrimental to that specific patient, then an honest and a thorough discussion should be had about the benefits of PEP in that instance. This chart is a little difficult to read, it's very small, but the resources that we send out to you after this presentation will include this chart, and it's a little bit easier to read. Next slide. So this is a medical practitioner's guide to appropriate PEP based on age, pregnancy status, and renal function. This is mostly just important for you to know that there are resources out there for practitioners who might not prescribe PEP that often and might need support during the process. There are preferred and alternative PEP regimens recommended depending on a person's medical status. Practitioners have many resources available to them, including online resources, as well as a hotline that they can speak with other PEP experts to walk them through best practice. Joanna will cover this more in her section. Next slide. So patients should be counseled as to what an acute HIV Sero conversion symptoms would look like. And if they happen, what are the recommendations for follow-up? Does the patient have easy access to the provider that prescribed the PEP medication? If not, what should the patient do? Should they visit their local ER? Should they visit their local STI clinic? Perhaps they should call the nurse hotline. Discuss what the concrete steps are that would make it easy to access the appropriate testing for an acute HIV infection. Discussion with the patient laying out exactly what to watch for is critical to ensure appropriate follow-up and treatment. There is follow-up guidance for an individual after the completion of their 28-day course of PEP. This includes follow-up HIV testing at 4 weeks, so right when the PEP is finished, 3 months and 6 months. Hepatitis testing at 3 and 6 months. Some STI testing is recommended at 4 to 6 weeks, and syphilis testing is recommended at 6 months. This ensures that other infections are caught and treated appropriately. Some infections take time to develop, and this is why the follow-up testing can be as long as 6 months later. Next slide. With any new medication, there are often side effects. They may vary from person to person, and they might have degrees of severity. Broadly speaking, PEP side effects are generally well tolerated. In the event that someone experiences an unpleasant side effect, it will most likely be a short-term problem with something like tiredness, diarrhea, dizziness, nausea, flatulence, headaches, and vivid dreams. These can dissipate over time, and again, some may not experiencing them at all. If an individual experiences side effects, you may be able to help them change their daily routine to help mitigate some of these side effects. Perhaps taking them in the morning versus the evening might help, and vice versa. Perhaps taking them with a large meal or a small snack might also help. Experimenting on when to take them and how it might fit into someone's daily schedule varies greatly. One thing is certain though, medication adherence is key. With any medication, if you do not take them, they will not work. Taking PEP as prescribed, i.e. daily, is key. However, when you take them is up to the individual. If taking them before bed works better, that's lovely. If taking them in the morning before they're brushing their teeth and heading out the door for the day, that works well as well. The important thing here is to find what works for that individual and run with it. There are instances you can see that there would be a medical emergency and should be treated as such. Those are rare allergic reactions such as wheezing, swelling, feeling lightheaded, or developing a rash with a fever. And all of those could indicate an allergic reaction to the medication. And if symptoms like these arrive soon after starting PEP, we would need to call the practitioner immediately. This may result in a medication change or discontinuation of PEP altogether. And this would be a decision made by the provider. Next slide. As we discussed earlier, there are biomedical HIV prevention methods both before and after an HIV exposure. We have been talking about PEP, which is appropriate for after a potential exposure. Let's switch gears a little bit and talk about options in anticipation of an HIV exposure or an individual that may have a regular or unpredictable potential for HIV exposure. If a person has risk that would warrant PEP consideration more than one time a year, or are in situations regularly that are out of their control, for instance, ongoing sexual abuse, then PrEP counseling should be offered. Next slide. PrEP, or pre-exposure prophylaxis, is most often a one pill once a day medication that contains 2 anti-HIV drugs and is taken prior to HIV exposure. This medication is taken by an HIV negative person either daily or on demand before engaging in activities that are high risk for HIV. Like PEP, this is obtained through a medical provider like a doctor, nurse practitioner, or physician's assistant. Like PEP, there are also labs that need to be conducted before starting PrEP, and a doctor may have discussion with about if PrEP is warranted based on risk or health status. For instance, PrEP may not be right for someone with severe kidney or liver disease. PrEP should also be taken by the person as it was prescribed and not shared with anyone else. HIV testing is imperative because if someone takes PrEP who is already HIV positive and might not know it, this is what we call an incomplete treatment and could complicate treatment options down the road. So it's very important that HIV testing is completed before an individual were to start PrEP. Next slide. So there are a couple of different ways that an individual might choose to take PrEP. Most often it's daily PrEP, that is 1 pill once a day. Here in the US, there are 2 options for PrEP. They're both very highly effective for all populations. They do have lower efficacy among people who are using needles to inject drugs. It is still recommended in that population if the individual can take PrEP as prescribed, so a daily PrEP. Taking PrEP when you are at risk for HIV, but potentially not very regularly, then some individuals choose to take PrEP, what we call as on demand. It's also known as intermittent, not non-daily, event-driven, or off-label PrEP. The type of on-demand PrEP that is studied is called the 2-1-1 schedule. And that means an individual would take 2 pills, 2 to 24 hours before sex, 1 pill 24 hours after the first dose, and 1 pill 24 hours after the second dose. There is scientific evidence that 2-1-1 schedule provides effective protection for gay and bisexual men when having anal sex without a condom. There's less known impacts on effectiveness of on-demand PrEP in individuals who are heterosexual men and women, people who inject drugs, and transgender individuals. So discussion with the provider around risk and then how to take it and how often someone is at risk is very important. There are individuals, for instance, someone who might not see their sexual partner, let's say more than a couple of times a year, or an individual who is engaging in certain risk behaviors very, very seldomly throughout the year. Those individuals, instead of taking a daily medication, might choose to do something like on-demand PrEP. Next slide. So PrEP is changing the game for folks who are at high risk for HIV. Individuals that might especially contemplate if PrEP is right for them might include men who have sex with men, transgender women, and sex workers. PrEP is up to 99% effective through sexual exposure and about 70-ish% in individuals who use needles to inject drugs. Any medical provider can prescribe PrEP after doing some basic lab tests, but this is not well known in the medical community at times. A lot of practitioners think that this can only be done by an HIV specialist. You can help by advocating for all primary care providers to learn how to prescribe PrEP to the patients that they see. This is helpful in situations where specialists may be more expensive and require referrals, which would increase the money and hassle for patients. We know that medical barriers are often difficult to overcome, and the risk of a patient falling out of care can be high. While HIV specialists are wonderful, it is not necessary to see one for a PrEP prescription. There are tools that a patient can bring to an appointment that can help primary care or family medicine doctors feel comfortable providing a patient with PrEP. Next slide. This is the PrEP Locator tool. It can be a great resource for you to be able to find PrEP in your community. So Joanna will help me out, we can go to that website and it brings up a lovely map, and you can actually type in a zip code that you live in, and you can find a list of all of the PrEP providers in your area. Is there a particular zip code you want to put in, Joanna?
I think we can do one in our region. So
Sure.
we are more in a city setting, so you will see there are a lot of options.
Yep. So all of these red dots are places that you can go to access a provider who will prescribe PrEP. Often the way that this happens is organizations who are PrEP providers will input this information into this slide, and then you get helpful information as far as sometimes you'll see names and phone numbers of providers inside of the institution. Sometimes you'll see some insurance options, costs, if a clinic is completely free of cost, or if they take insurance, those types of things. There are times in which sort of rogue information gets entered in here, as far as, let's say, like a minute clinic at a Walgreens location. Those are not places that will prescribe this type of medication due to the necessary follow-up for PrEP. And so if you're a little suspicious about whether or not a place might offer, a phone call or sending an email might be your best bet.
I'm going to do one more that gets us maybe a little bit more north. Just see that there's a good reach still.
Yep. And this might help to have a conversation with a patient who's interested in PrEP, just kind of helping to plan that trip. So, you know, would traveling maybe 45 minutes to an hour outside of your community work for you? And if not, then let's try to find a different option. Or, you know, it just kind of helps plan the action of whether or not a patient is able to get themselves to the location. If you potentially are in a more rural environment where the PrEP access might not be as concentrated, let's say.
Ruthie, this is Angie. I have a question.
Yeah.
So I know that PEP and PrEP are two different meds. How likely is it that the folks on, like, when you're using this locator, how likely is it that these places will have PEP too?
So this is specifically for PrEP locator. And so there could be some overlap there, but I think Joanna will dive much more into how readily accessible PEP might be at these same locations.
Perfect.
But this tool is specifically focused on sort of the action of PrEP. So a little bit, you're not up against a time clock like you are with PEP. And so, you know, this is a good tool to kind of help plan future needs, as opposed to an emergency situation like PEP would be.
But it's a super fortuitous transition, Angie. So I'm going to dive into the kind of nitty gritty of PEP and give all sorts of resources. And because there's a lot of detail here, I am just fine. If you have in real time questions, throw them in the comment box, and we will just answer them as we go, so that you don't have to try and remember which slide I was talking about when you ask. So the immediate answer to that, Angie, is there's a decent amount of overlap in terms of whether they would actually have the medication, but the probability of the site that is prescribing PrEP being prepared to be responsive in that short window of time for someone who needs PEP is pretty low. There is overlap in the medication. So as Ruthie mentioned, PrEP is one pill, two medications in one pill. PEP is two pills that will make up the three medications that are needed. So they will likely have them or would be familiar with them, but that window of time and the comfort of follow-up is less likely. So let's say you're working with somebody, or you are somebody that has an exposure and you're feeling like you need to get access. The first thing that I do often, and I get a lot of calls from people, whether they've been exposed through a sexual assault or through a sexual encounter, or whether they've been sharing needles with someone, we will talk through whether the risk is one that would warrant prescribing. I am not a prescriber, and I'm really clear with people about what we're talking about in terms of mitigating risk and processing that anxiety that Ruthie talked through. I will agree that anxiety sometimes is 100% of the reason to treat with PEP, and I can give all sorts of stories around that if you're curious. But talking through what that exposure really was is very helpful in understanding how quickly we need to help somebody get access, and often it can help somebody understand if the access is necessary. The really important piece is understanding when the exposure happened. So in an ideal state, an exposure will have happened, and within hours that person has access. But often, for a variety of reasons, that person may not get to somebody or to a prescriber until they're pushing the clock of, hour number 60. So understanding right away when the exposure happened is going to be really important in terms of timing. I will note I am in Milwaukee, and we have hospitals everywhere, and my hospital where I am based is the only one that will prescribe PEP on the spot. So it happens many times where someone will walk in to an urgent care, to their primary care, or even to an emergency room and report an exposure, and they get turned around because they can't do what is necessary for PEP. And that is in some cases, even in cases of sexual assault. So if you're working with somebody or you are somebody who's seeking PEP, it is really helpful once you either talk to somebody or assess yourself whether there's time and that there's validity in needing to access that, is trying to identify where to go. And further along the line, I have a slide and some resources to share in helping identify that. But the places to look and honestly to call, because nobody puts this on their website, like, hey, we prescribe PEP, is emergency rooms, urgent cares, and public health clinics, depending on your location, will potentially have access to PEP and are in a position to prescribe within that 72-hour window that's so important. As I said, people really can be turned around. I have worked with many people who have gone to an ER and been turned away, and then gone to an urgent care and been turned away, and called their primary care doctor, and their primary care is like, I don't know what that is. And so I'm the 4th or 5th person that they get to, and now we're on hour number 54 after the exposure. And so it's critical that we get it in that window of 72 hours, but if you're supporting someone in going through this process, really sticking with it and encouraging them that we will find someone. It's just a matter of persistence, but it's certainly a point of anxiety when you've been working through the steps and you just can't find somebody who's familiar. As Ruthie mentioned, there are resources for clinicians as well. Physicians and nurse practitioners can prescribe PEP, but many aren't as comfortable as they would like to be. So the National Clinician Consultation Center can serve as that resource. They have someone who will answer calls, and it's physician to physician consult. There's resources on their website. And I will say that even though it's clinician driven and clinician directed, it's really helpful to surf around that website and understand some of the resources that they have offered there for you or for anybody that you're supporting in accessing PEP. So I want to talk through the process of what it looks like for someone when they come in to report a sexual assault. I understand many of you are well-trained advocates and have probably gone through this experience with someone. I want to just speak from the position of the person that gets connected with the individual during and after, and I'm happy to answer any questions. Again, I work at the one hospital that prescribes PEP in Milwaukee, and so that I speak from that experience. So if somebody comes into our ER and reports a sexual assault, the SANE nurse is always alerted. We have a SANE team, for instance, that responds to our 5 emergency rooms, but they are not stationed at one specific emergency room. So it can happen that the person might wait 45 minutes or longer for the same nurse to arrive. As many of you know, a patient advocate is always offered, and if the person is accepting, assigned, and then they arrive as well. It happens a fair amount from my end of things that the person will either decline the patient advocate, and I think in part, sometimes it's because it's not pitched well to them, or maybe they don't fully understand the support that can be offered. But they'll accept me coming in, which is interesting. So being the social worker, and I am often presented to the ER as the person who can support them from a social work and clinical perspective, I will get involved alongside the nurse through the process, but I don't serve as an advocate, and I do not have that level of expertise. I am the only social worker in our hospital that does this, largely because I'm the social worker that is also based in the infectious disease clinic. So I will see people after the fact. So I help support them getting access to PEP in the ER, but then the process afterwards that Ruthie briefly went through in terms of follow-up and testing, I'm part of that. And so I think sometimes that might be what helps people feel like I can support them and get connected to them, because I exist afterwards as well. So they'll have an exam done and hopefully be provided with a resource folder. My experience has been, even within our emergency room systems at the hospital that I am based at, it depends on who you get and what you'll get in terms of a resource. So I have seen people left with like a really nice folder and packet of resources, and then I've seen people come out with an envelope, and certainly that's also not a time where you're really processing what's being given to you. So I've also seen people say, they gave me something and I don't know where it went. So that can be a challenge, because often within that document or those resources, information about what's been prescribed to them is contained. So the follow-up piece is going to be really critical, both from an advocacy standpoint, as you all know, but also from a health perspective. So folks will be directed to return to our clinic once they have completed their PEP course. That certainly doesn't always happen, which is part of why I'm notified when somebody reports to the ER, so that I can help do outreach and assist them in coming back in for that follow-up testing. We work very hard to help connect folks to mental health support. And while, again, I am far from the expert, we have some resources around legal action and how they connect with the DA. One thing that I do frequently get involved in is cost, especially for something like this. There is a process through which costs can get dismissed from an insurance billing perspective, but it is tedious and sometimes not done well. And that's re-traumatizing when someone is billed for an exam related to a sexual assault. So I will frequently intervene in support of navigating the billing process and correcting possible errors that could be made. And I can talk more about that if anybody's curious. So there are SANE.
I have a question, Joanna.
Yeah.
And you might be getting to this later, so I apologize if I'm getting to it beforehand. Throughout our conversations, because Ruthie, you and other staff from WCASA and I have had conversations prior to this, I've always been curious about why is it so few places provided? Why is it so difficult to access it?
In terms of PEP itself?
Yes.
Yeah, it shouldn't be. I agree. We can do a better job as a health system in empowering providers to feel comfortable with this resource in prescribing it. As Ruthie said, any physician can prescribe PEP or PrEP. It's not difficult, and there are algorithms that are very straightforward. So it should not be as difficult as it is. I will say, and so I've been here for 11 years, many years ago, my pharmacy partner and I worked very hard with our ER to make it possible so that PEP would be dispensed from the emergency room as the person walked out. So that in and itself was a huge undertaking, in part because of billing and in part because people were afraid that if they dispensed a partial set of meds, which is what we do 5 days so that the person has time to access and fill the prescription after they leave. It made people nervous. What if the person doesn't fill it? And then we've dispensed 5 days of medications, and does that put the person at risk? So it is always, from my experience, coming from the best intentions of, not wanting to put the person in a position of unsafe risk in terms of accessing medications, but it's almost never warranted. We could do a better job.
Yeah, it seems like it always goes back to intent versus impact. Like the intent is good, but the impact is very few people are having these conversations. Knowledge about the medication in and of itself, it seems to be very lax. Sarah and I were doing research, so we called pharmacies around the Madison area, the capital of Wisconsin. And there were, I think I got to like 5 pharmacies, and more than half of them, when I asked how much does PEP cost, they didn't know what I was talking about, which blew my mind. And I was talking to the pharmacist, not a pharmacy tech, the actual person who went to school to learn about all of these medications, and they knew very little about it. It was very eye-opening as to why we need to have these conversations over and over and over again, because such a short window of time in order for the medication to be effective.
And I'm going to talk about pharmacy shortly. If I don't say something about that, remind me, but I'm getting there.
Joanna, there was one other question in the chat from one of our participants, Gwen, who asked, and this might be something you're covering later, how does local health departments, if any, play a role in following up with PrEP care? Now, Gwen, did you mean PEP or PrEP? I'll let you clarify if I misread that.
So I'll jump in. So I used to work at a health department here in Milwaukee, and there are some health departments in some areas that do prescribe both PrEP and PEP. It's not very common, and it's relatively new. I think the Milwaukee Health Department just very recently coordinated with another local aid service organization here in Milwaukee to provide PrEP out of their clinic. And so it's not very common. And usually, unless the health department is providing the PEP or the PrEP, they won't have anything to do with follow-up care at all. They might be a place where clients will access certain HIV and STI testing that's required to be on PrEP, which is a pre-exposure prophylaxis, but oftentimes the health department will have nothing to do with this just because they deal with reportable diseases, and unless the person contracts HIV, they won't have any follow-up or care provided to those patients.
Thank you.
So there are 54 counties in Wisconsin that do have SANE programs. They are not all hospital-based. You do not have to squint and read this. I just wanted you all to get a sense of the vastness of SANE resources. I have a much more detailed document, including addresses and phone numbers and points of contact, that will go out after this presentation so that you can keep it as a resource. This is an ever-evolving document as well. We were talking prior to joining this call about the published version of this through DOJ is out of date. So this map and list is actually homemade, and I imagine in 6 months might look a little bit different even. So we'll make sure that everybody gets this afterwards. So as Angie was talking about, it's really helpful to know your local pharmacies and know your specialty pharmacies. So part of the barrier in pharmacy resource, Angie, as we were talking about, is that the medications for both PEP and PrEP are considered specialty medications and they're expensive. And so while a pharmacist should know about them, I agree, and be aware of the resource, often pharmacies don't carry these. So this is the issue, and it happens here as well, that when you see someone in an emergency or an urgent care setting and you give them a paper script or you send it to the pharmacy they tell you they go to get their asthma medication, and then you say, goodbye, good luck, they may go pick up that medication and it's not in stock. And so if that's for a PEP person, that wipes out our opportunity of supporting that person, because let's say it was hour number 50, they spent 4 more hours in the ER, and then they leave with a paper script, it's 2 o'clock in the morning, they can't fill it until 8 o'clock, now it's 62 hours after exposure. So this is in part why my pharmacy counterpart and I advocated, for instance, here, that we dispense with 5 days of medication so that you would have that time for all those mistakes of going to a different place or the place having to order it, as well as knowing that they're protected for those days that you're working through that. So identifying specialty pharmacies is really helpful. The 2 largest pharmacy branches in the country are Walgreens and CVS, and they have specialty pharmacy locations throughout the state. We have 2 in Milwaukee, there's 1 in Madison. They are not widely dispersed, but the helpful thing to know is that those pharmacies that have specialty hubs can transfer medications to a different version of their pharmacy. So if I want to pick up a medication at my local Walgreens, which is not a specialty pharmacy, the specialty Walgreens in my area could courier the medication to my local pharmacy and I could get it that way, usually same day. So it is always helpful to identify specialty pharmacies. This is not also a shameless plug. I said to Ruthie, I felt a little funny putting Froedtert and the medical college on here, but we're a specialty pharmacy. And so I will sometimes facilitate folks who don't even come here for care accessing our pharmacy because we can guarantee that it's in stock and we want them to be able to get access to it quickly. Specialty pharmacies and just general local pharmacies can do a lot of things to support a patient if they know that that support is needed. So there are copay cards, which I will go into in more detail, but they assist in paying for copays related to medications. And pharmacy technicians can activate those for any drug, quite frankly, if you ask for it. And really, you can just say, can you find out if there's a copay card for me? Often they don't know. We have a pharmacy technician who's based in our clinic, for example. She's an expert in these things. She gives talks with me in these things. And pharmacy technicians go to those and go, oh, okay, and take notes. But they do have resources to do a deep dive. So if you just ask for copay assistance, they know how to go and look. They are also always in a position to reach out to a specialty pharmacy and ask for assistance in navigating other assistance programs, which I will get to. So I think the key takeaway here is identifying your specialty pharmacy and being confident in asking for help are pretty surefire ways to get at least some steps forward in getting access. One of the things that Ruthie and I were talking through as we were preparing this for you is understanding that while you aren't going to be prescribing or may not necessarily get to be in a position of being that advocate if the person doesn't say yes, or all the reasons you may not be one-on-one with the person right away, knowing how to support that person through the process is immensely helpful. And it starts with what you're doing today, which is knowing the facts about what works, what doesn't, what it's called, what it's not called, who's eligible or appropriate for it, can be a really big step, because if you're a source of just, even if it's just basic understanding, that can go a long way in helping with that anxiety through the process. Being able to call and text reminders if someone is started on PEP or is taking PrEP is a really big help, especially when somebody's new to the process. So just being able to do a quick check-in, to help somebody set an alarm on their phone so that they don't forget. If someone's not used to taking a medication every day, they're not going to remember. So helping people identify, you know, what do you do every day at roughly the same time? Do you brush your teeth at the same time, or does your alarm go off? Do you watch the news at a certain time? And helping link those things to taking the medication can be very helpful. Supporting folks with rides or bus passes or other access in terms of transportation is huge, and understanding pharmacy and insurance. You don't have to be fluent, but understanding a little bit of what we're talking about today so that you can say, hey, let's go find an expert and let's go to a specialty pharmacy and find an expert on that. What's important to know is PEP is 28 days of medication, 2 pills. You will always get 30 days. And that's because that's a normal bottle of medications. No pharmacy will bust open a bottle and take out 2 days worth of medications. So if somebody is prescribed PEP and they leave with a script, they're going to have somebody tell them, you know, it's 28 days, they're going to get a bottle of 30 pills. And that can be confusing to people. They're going to get a bottle of 30 pills even if they were, let's say, discharged from an ER with 5 days of medication. They're getting the full pack. And so I tell people to just take the full 30 days. It does not hurt anything to take 2 extra days. If you've already been dispensed 5 days, then, you know, fine. They may not take the full extra 5 days, hang on to it, or, you know, you can recycle it through a pharmacy. But I like to prepare people because that can be a little unsettling. You wouldn't necessarily think that it would be because we're, as a culture, used to getting a month's worth of medications. But when you're having it drilled into you, I have to take 28 days of this, and then someone hands you 30 days, it can be a little bit off-putting. Okay, so medication assistance, there's all sorts of great resources and accessing support for folks who might need assistance in the cost of PEP or PrEP. Copay assistance cards are basically, I like to describe them to people in the simplest way I know how, which is kind of like a free credit card that will cover some of your drug costs. So you register yourself, and that's why I'm talking about the Gilead copay card right here at the top. You'll register the person or yourself for this card, and this card gets designated to each individual person that it looks a little bit like an insurance card. It has a special number on it that's just for the person that registered. And that will cover up to $7,200 worth of copays for one of the medications that is in the PEP, traditional PEP regimen, or PrEP itself, which is Truvada. The way it works is that the medication first gets billed through the person's insurance, and then if there's a copay related afterwards, it will get billed through this copay card so that there should be no cost to the patient. And that $7,200 is over the course of a year. And so if I have a $100 copay, let's say I'm on PrEP, which would be once every month, I would potentially be filling it. I may have a $100 copay every time I fill it. And so this card would cover that $100 every single time I fill it, because at no point over 12 months would that reach the $7,200 maximum. Those copay cards, though, however, can only be used for folks with private insurance, and that includes insurance through the marketplace, also known as Obamacare. So if somebody has Medicaid or Medicare, they can't use a copay card for any of the cost. Now, Medicaid is pretty negligible. You can get PEP or PrEP through Medicaid, and the copay, if you have one, is maxed out at $3. So that's not a barrier typically for people who are accessing it through Medicaid. Medicare, however, if you have not met your out-of-pocket medication costs for Medicare, this could be a big deal for you. And if you can't use a copay card and you potentially have a $500 or $1,000 copay because you haven't met your out-of-pocket drug costs, I know I'm going down like the Latin hole of insurance. I'm trying to pull myself up. The point being that Medicare could lead to a really significant drug cost if you're trying to access this for either PEP or PrEP. So there are other privately funded patient assistance programs that's just important to know they're out there. And so when I referenced that a specialty pharmacy technician should know some basic pieces of this, and even if you said, hey, I know that there's a patient advocate foundation. Could you help sign this person up for that? They can then go through the process of signing the person up. So the Patient Advocate Foundation, for instance, will help copay assistance for individuals who are 400% or below the poverty level, and they'll help with any drug costs. So if, for instance, the person's insurance for whatever reason doesn't cover it at all, then they could run it through this. If they were uninsured, they could cover it through this. And the Patient Advocate Foundation does that up to $7,500 in a year. The Patient Access Network is a similar program for people who live at or below 500% of the federal poverty level. I thought about putting that chart up here, but I think that might be too much in the weeds, but we can send that out if folks would find that helpful. I will note, though, that the PAN or Patient Access Network is literally always closed. However, I always check it because, you know, that one shot. I have gotten people on it in 11 years, but it's very rare that it's open. And then Good Days is a program specifically for folks who have Medicare or military-related insurance, and that is for folks who are living at or below 500% of the federal poverty level. And then finally, you may know about it, but Needy Meds is a website that can help folks access copay cards or other resources, not just for PEP or PrEP, but also for other medications. So we use that as a resource for folks if we've worked our way through this and we're not finding a way, we'll go there. For PEP specifically, time is of the essence. If somebody has a barrier in accessing the medication, if they're uninsured, we will go directly to Gilead's Advancing Access Program. And this is a program that will give you the drug for free, basically. This over here on the side is what a copay card looks like. I couldn't squeeze it in on my other side. So if you access a copay card for somebody, which you can do for PEP, that is what that copay card will look like. And what's important to know is that if the person is prescribed PEP and we've gone through all those options of activating a copay card or trying to use Medicaid or Medicare, and that's not a resource, we want to make sure that the person gets it. Gilead's Advancing Access Program, which the application, one of the 3 pages is on the left, will prescribe the drug or will provide the drug at no cost. But again, you need to be doing it through a pharmacy that knows what they're doing. So our pharmacy, for instance, or a specialty pharmacy through Walgreens or CVS knows this program. We know what has to be provided, which is just a copay, or I'm sorry, proof of income, and that can just be self-attestation as well as ID, literally, and that's it. And the pharmacy can dispense it immediately. So that's important to know because you don't want to be running around trying to figure out if you have drug coverage, or I have also used this for folks who have to use a mail order pharmacy, and that's not going to be in the person's hand in 72 hours if they need to do that. And so we'll use this program because we know that we can get it directly in the person's hands. I'm going to pause here because I feel like I went down the rabbit hole of insurance, which is a little bit like Latin. And thankfully, most people don't speak Latin. So if there are questions about some of the things I just said, have at me.
I'll give folks a chance to type if they do have anything. But Joanna, I was wondering, you sort of just alluded to this. If we, for instance, have a survivor in a rural area who shows up, you know, to an ER that's located right in a rural area, and the advocate there is trying to get them access to nPEP, is this the route that you would take? Because those 72 hours, right, are so critical.
Yes. Yeah, I would, if I was in a rural setting, I honestly think what I would probably do is try and identify a specialty Walgreens and personally call them myself and say, hey, I'm not coming up with a good, I'm in Berlin, Wisconsin, and could you work with me and the Walgreens down the street from me in getting this medication over to us like stat? Because again, they do have courier service. Every single Walgreens does. It's one of the things they tout on their website. So if you're talking to someone who acts like they don't know what you're talking about, stick with it. Because that would ensure that the drug is coming, you know, there's a partner at the site that you're in, and I'd push that way. If you're in an emergency room that has a pharmacy connected to it in any way, they should have access to these medications unless you're in like a 3-bed hospital, which is certainly possible. But if you're in a decent size, I would say 100-bed or more hospital, these medications are typically limited, but are kept in stock like 1 bottle. So that can be helpful. The other thing I would do if I was in a really small emergency setting or urgent care hospital setting is I would start calling around to other hospitals and asking if they have it in stock in their repository. So a repository, in case anybody on here isn't aware, if medications are dispensed and never opened, they can be sometimes returned, but they can't be billed. So if I, let's say, am living with HIV and I got my medications and then they switched my medications and I never opened the bottle of my last ones, I can turn them into a hospital and they'll give them away for free. They can't reissue them and bill Ruthie's insurance for them and then give them to Ruthie. But they could, Ruthie could be identified as somebody who doesn't have a resource to pay for that, and they could give it to her for free. So I would probably spend some time, you know, an hour calling a couple different larger hospitals and asking, 1, if they have it in stock, and 2, if they have it in a repository.
Awesome. Something that I'm sorry, Angie. I was just going to say very quickly, Joanna, you don't have to speak to this because I do think it'll come up in part 3, but regarding costs and the SAFE fund through DOJ, there is some ongoing action there around that cap, and is PEP covered? And I think we've determined that nPEP does fall under, right, the definition of what can be covered there, but that is something that we will probably address in part 3 if anyone is wondering about that.
So I feel like the big takeaway is there's a lot of prep work, and I don't want to confuse that with prep. And there's a lot of preparation that I think my hope is that advocates take from this is that there can be some work that needs to be done ahead of time, considering there's this tiny window, knowing, you know, sometimes people are raped or assaulted, and then they may not report right away. You may not, as an advocate, you may not get the call right away, so that reduces your window. And then the exam itself, if you are accompanying them at an emergency room, that takes some time. So you're in a time crunch, and then trying to figure out the payment plans or the payment assistance programs that are available, trying to find a pharmacy that can dispense the medication. The repository is something I hadn't heard of, which could be an incredibly important resource. So it feels like there's so much, and I don't want to overwhelm folks. There seems to be some work that can be done ahead of time, right? That can make it easier when you're working with folks, survivors, because we know the trauma exposure response. We know someone has gone through a very traumatic experience, and that's a lot to give onto someone in a short amount of time. All of these things that the survivor has to think about. And now we've added potentially something more. So there's a lot that advocates can do. And that's another reason why I'm so excited that we're having this series, so that we can have these conversations and be aware of. And I think that's also something that Amanda's going to talk about next time, is when you're working with folks as an advocate, you have to understand how trauma can be impactful and can impact the survivor in this instance.
You just led us right to our next slide.
I'm like the leeway person for y'all today. Like, this is great.
So yes, I agree. It's all about knowing your resources, and it can be overwhelming when you hear it all in one setting like this. But yes, knowing that there are resources, spending a little bit of time learning about those. There's some really great resources through the CDC, both on PrEP and PEP, so that you can just go through some of what Ruthie and I talked about, but also identifying regional and local resources that folks can use can be really helpful. Health departments can be really helpful. They aren't always, but they can be. And just understanding what's out there and orienting yourself. I am not a sexual assault advocate, but because I often get involved in the work here, specifically in our ER, I would completely echo what Angie said. I think a lot of times part of why people are open to working with me, and then I'm the one they'll call afterwards, is because I'm the one that comes in the room and is like, no, don't ask them all that. I got it. You know, they do get bombarded with, do you want to start this medication? Do you know what, you know, do you want to get all of these tests? Do you want this to happen and this to happen? And it's too much. So understanding how to get somebody access, and then you preparing, okay, they're going to have to come back in a month. And that's ideal. A lot of people don't. And then they're going to have to remember to get tested in 3 months and 6 months. And giving somebody all of that in that moment is unfair. So being prepared with that information is so helpful, because it'll come up again. And it doesn't always need to come up in that immediacy of things. If you know it and you're connected and can share it when they're ready, you know, hey, you've been doing this for 20 days. Remember, let's schedule you a follow-up appointment so that you can go in and get that 4-week test, can be invaluable. So I'm going to say thank you and open us up, both Ruthie and I, for any questions.
I think one thing just quick before we move on to that is it can seem overwhelming. I work in a clinic and I have lots of folks who will come in with very high amounts of anxiety because they did not know that something like PEP existed and they had a very high risk exposure. And, you know, working through the time it takes for a potential HIV infection to take hold and then to test positive on a test can be, you know, upwards of a month depending on the type of test that you get. And so, you know, imagining someone sort of dealing with that stress and pressure for that entire month is very, you know, kind of harmful for them. And so often, you know, the one thing that they say is, man, I wish that I would have known about this beforehand, or I wish I would have been able to get it beforehand. So while it does seem very complicated, the impact that, you know, your advocacy has on a patient is huge. And so while it seems complicated, I would just encourage you to, you know, get the resources in advance so that if this does come up, you can help that individual work through that, because it's a very complicated process, but the impact that it has on a patient is really, really big.
And Ruthie and I frequently work together when those sorts of people come into the clinic that she works in. You know, we talked here about supporting sexual assault survivors. We certainly support folks who are just exposed through sex with somebody that they may not have known or whose status they didn't know. And for those people, this list of resources doesn't exist. So if you walk into an ER and say, I just had sex with somebody I don't know and I'm scared and I think I should get on PEP, you'll get turned away outside of our ER. You'll get turned away from your primary, you'll get turned away from an urgent care as well. So sometimes that persistence looks different for somebody who isn't in a position to be in the ER for a terrible reason. And I would even add that it also looks different for folks who are victims of same-sex assault. So they don't have the same experience. And knowing these resources and knowing places like, you know, where Ruthie works and knowing that you can connect someone in the community is, yeah, again, invaluable.
And I would say too, take advantage of the context that you might have in your community. If you know someone who is really adept at working through this process, take advantage of that. I'm texting Joanna all the time being like, hey, you know, I'm sending this guy to you, you know, he's going to be there in 20 minutes, you know, can you help him walk through the process? And she texts back being like, yep, got it. So, you know, those types of working relationships, you know, even inside or outside of your own sort of place of work is huge too. So I would say, you know, if you know somebody like a Joanna in your community, get their cell phone number and text them when you need some help navigating the process.
Thank you both so much. I had one other additional question myself that might also be discussed in the next part of this series, but I'd love your input. In your experience and based on your knowledge, would you say that the role for the advocate here becomes really crucial because SANE nurses, right, who might be responding to survivors, you know, is this knowledge well known by all SANE nurses? Do you think it's really dependent on location, and is it more variable, or can we count on SANE nurses, right, having access to the resources and the information that you have just provided us?
So again, I can only speak from personal experience, but no, they don't know the level of information that I just shared here. They know which tests to offer. They know which medications and what to treat you for. They know often that people like me exist. They trust that the advocate is going to take it from there. So I've never, and I work really closely with several of our like lead SANE folks. They don't know this. They know the clinical expertise, which is what we're counting on them knowing. Right. But they don't have this level of information. And even if they did, they wouldn't know what to do with it, right? Like, because they're coming in for the clinical exam and the support around that. They're counting on other people doing this. And I have worked with SANE nurses who are stunned with how hard it is to get access to this. One of the people that was instrumental with my pharmacy partner and I in getting the 5 days dispensing plan was our SANE nurse, because she couldn't believe that they weren't already doing it. And so advocated heavily on like, yes, we need you to do this, because I just give them a script. And if you're telling me they may not get it, then I'm not doing the job fully that I am expected to as a clinician. So I think your SANE nurses, if you know them, can be really strong advocates in helping set up systems that are more patient-friendly and efficient. But I would never trust a SANE nurse to know the level of information around access that we discussed here.
Sure. And I think, I mean, that's a hole, so to speak, or a gap in some of this that we might not anticipate as advocates. I know that typically if we're coming into contact with a survivor through the ER, right, that's a SANE response. But for some of you, that survivor might be walking into your office during crisis hours. They might be a walk-in, right? They might not be presenting at an ER. You might not be responding to the SANE call. And this information is still so crucial, right, to help them know what to do next, like what sort of process, right, follows to make sure that they feel safe, right, to make sure that they feel that they're getting all the help that they need after the assault.
Yeah, and especially if you're with someone at 2 o'clock in the morning, like knowing this information, access, cost, payment assistance programs, insurance, knowing all of this ahead of time, because you might not have that community pharmacy available at 2 o'clock in the morning. Your pharmacy options are going to be limited, especially if you're in a rural area, I can only imagine. So knowing all of this information ahead of time, making sure it's a part of your paperwork, knowing how to ask these questions. These are some things that Amanda will be covering next time in a trauma-informed way is especially crucial. And so advocates, you are an incredible resource for the folks that you're working with. We already know that. So you're adding this another essential tool in your toolbox, in your toolkit, so to speak, in order to help the folks that you're working with, because the resources are so difficult. And then you're adding all these other difficulties: location, time of day, the time the survivor comes in to access your services. So knowing all of this ahead of time is so incredibly crucial, as much as you possibly can.
And I was just going to mention one thing from my slides as far as follow-up testing and sort of baseline testing. Even if a patient that you're seeing might not be in the right 72-hour window, a lot of that testing can look the same even without PEP. So just sort of maybe a reminder for advocates that they could also potentially play a role, even if a patient missed the 72-hour window, that sort of testing can still be accessed. And an advocate could definitely be the person to potentially remind a patient that, like, hey, it's about a month. This would be a really great time to access an HIV test. You know, hey, it's about 6 months. And so this is about the time to let's do a follow-up syphilis test, that kind of thing. So some of that stuff can even be helpful, even in the absence of PEP as well.
That's a great point. Yeah. And what happens if you are working with survivor after that 72-hour window? Like you just said, Ruthie, reminding them that after a certain amount of time to be tested, even though you weren't able to access that medication. That's a really great point.
I'm sure many people in their role as advocates here can relate to this story, but I recall many times when I was helping survivors, if they were nervous to make that call, right, to go and get that testing or to see where they could access the resources, they can plan on making the call, you know, in office with you, so that at least, right, you know, the role of the advocate has so many opportunities to really be such a huge help in the process of accessing these resources and getting the help that they need. Are there any other questions for Ruthie and Joanna? I also know that sometimes a question comes to us like 3 days later, so thankfully we have their information there if you'd like to follow up with them after this webinar.
And you're always welcome to email Sarah or I if you have any questions. Like say you can't locate Ruthie or Joanna's contact information, please don't hesitate to reach out to Sarah or I, and we can also reach out to Ruthie and Joanna on your behalf, or share with you their contact information.
All right. Well then, with that, I mean, on behalf of all of LaCasa and all of us, Ruthie and Joanna, thank you so much for your time and your expertise. This was amazing. The information is so incredibly helpful. For folks who are watching, Ruthie and Joanna will be sharing some resources with us that we will send out to you after this webinar. So in addition to any notes that you may have taken, we'll be sure to pass along that to you all. Please take care of yourselves, enjoy the rest of your afternoon, and join us on Tuesday the 6th for part 3 with Amanda Schumacher, where we're going to be talking about trauma-informed advocacy to survivors, specifically in response to, right, navigating the system around HIV exposure and resources.
Thank you, everyone.